Thank you so much, Dr. Jaitilaka, for your kind introduction. Actually, this is my very first lecture as an acting consultant, so I'm a bit anxious and nervous. But before going for the main topic, I thought, as Dr. Jaitilaka correctly said, I'm new to this hospital, and you may not know what can I do in this hospital and what is uh, nutrition service and what is nutrition care actually we can provide for the patients and what we can do. Therefore, I will take about 5 minutes from my time to give an introduction about what is clinical nutrition is as a subspecialty. So please see this patient. He is a young patient who underwent a high velocity road traffic accident and admitted to our nearby main hospital, National Hospital Kandy, with a good nutritional status. However, he had so many lethal injuries head to toe, and with a very long ICU stay of 55 days. And this picture was taken on the day of discharge. Just look at him. His normal weight is 60 kilograms. At this point, it was 40 kilograms. There had been a 20-kilogram weight loss during the hospital stay. So he had acquired malnutrition during the hospital stay. So keep that in mind, and let's go to the next few slides. So the clinical nutrition service and medical nutrition therapy actually deals with the nutrition of the patients, and you have to understand that about 30 to 50% of hospitalized patients are malnourished. Either they admit with malnutrition or they become malnourished during the hospital stay. So it's a big problem because it directly affects the clinical outcome of the patient. And we deal with various areas like obesity, nutrition in diseases, critical care nutrition and preventive sector and special diets for obesity and all. And also, uh, ideally, there should be a nutrition support team dedicated for the hospital. So, who are the people in a nutrition support team? The nutrition support team is led by the board certified consultant nutrition physician. This is related to our country, right? And then in the hierarchy, the next person is acting consultant or senior registrar, then registrars, medical officers in nutrition who hold a special degree, the MSc in human nutrition. And then come the nutritionists and dietitians, nutrition specialist nurse who are not here in our country, and clinical nutrition pharmacist is also, those pharmacists are also not in our system, nutrition coordinators, diet clerk, and the kitchen staff. So this is the ideal hierarchy where the nutrition support team should consist of. Here, no one else but myself as acting consultant and the diet clerk and the kitchen staff. Okay. Then I would like to take you through a few evidences and guidelines. These are actually not nutrition guidelines. These are the guidelines which are internationally accepted for management of this particular disease. So the ADA guideline is the widely accepted one for diabetes care. So it clearly says that nutrition therapy, uh, the the consensus recommendation you can see differ adult living with type 1 or type 2 diabetes to individualized diabetes focused medical nutrition therapy at diagnosis and as needed throughout the lifespan and during times of changing health status to achieve treatment goals. Coordinate and align with medical nutrition therapy plan with the overall management strategy, including use of medications and on an ongoing basis. So when you diagnose a patient with diabetes mellitus, at that point, you have to refer the patient to medical nutrition therapy for specialized medical care. It is not a supportive measure. It is a integral part of the management of a diabetic patient. So it is clearly said in the ADA guideline. And look at this forest plots. So this particular systematic review and meta-analysis of nutrition therapy compared with dietary advices. So one group has been given a specialized tailor-made nutrition therapy, and the other group had been given just the dietary advices like we do now. So there's a significant difference. You can see the HbA1c, there's a significant reduction when compared to the dietary advices, and the LDL cholesterol, there's a reduction. So likewise, with the proper nutrition care, the medical nutrition therapy, we can actually facilitate the medical management of a diabetic patient, and we can achieve favorable outcomes on top of pharmacotherapy. So it is very important to understand. So in our setup, we may think like our people can't afford high-fi food varieties, supplements, and also let's just ask them to eat anything they want and just prescribe the pills. Will it work? No. The medical nutrition therapy actually helps to reduce the pill burden of the patient and delay the initiation of insulin therapy. And of course, what I'm going to tell next is about the diabetic remission. If you have heard it, you may know that. Benefits of successful weight reduction. So our main area is the management of obesity and overweight and weight reduction. What is successful weight reduction? We can't just tell the patient reduce the things you eat and reduce your weight. The successful weight reduction is actually we have to preserve the lean mass of the patient and the muscle mass of the patient, and specifically reduce the fat mass and get to a weight loss. So that is very important. So you can't take just reduce what you eat. So the patient will become sarcopenic and frail at the end of the weight loss period. So that is very important. So diabetes remission. What is diabetes remission? This concept is really, really important in our country at this era because a lot of patients are being diagnosed to have diabetes in very, very early stages. So we sometimes don't have to take preventive measures. In younger age, they come with diabetes. So there's no place for prevention. In that particular background, the remission is really important, and this will become a major area of management in diabetes in next few years. So what is remission? That defined as HbA1c less than 6.5%, then persist for at least 3 months in the absence of glucose lowering pharmacotherapy. So this, let me take the cursor. Yeah, this particular trial, which is well-known trial, the direct trial, it actually showed to the world that with a successful weight reduction, we can go for diabetes remission. So you can see that intensive weight management induces remission in type 2 diabetes in 46% of the participants at 1 year, compared with 4% receiving usual care. And the remission percentage is low, goes up with the percentage of weight loss. So this is very important. And also the successful weight reduction reduces HbA1c and markedly reduce need for glucose lowering medications and improves quality of life. So this is a new, not new actually, but which can be applicable for our patients more and more. That's why you have to be vigilant on this and prioritize the patient and refer for medical nutrition therapy. So we have a window to achieve a remission if you refer the patients early for medical nutrition therapy, because this works only on newly diagnosed patients. And what are the other benefits of weight loss? You can see that even less than 5%, 2-3% weight loss can help to prevent diabetes, dyslipidemia management, and HbA1c control. And usually what we target is about 10% weight loss of patient. We don't want to make the patient's BMI normal. Even in an obese patient, if we achieve 10% weight loss, he actually benefits with a lot of uh, beneficial clinical outcomes. You can see 3 to 5% weight loss reduces triglycerides, blood glucose, so and so. So it is really important to achieve a successful weight reduction in the patients. Not only diabetes, in renal disease, these category guidelines are not nutrition guidelines. You refer them for your patient's management. So there also, the first line of the management is healthy diet, physical activity, and weight management. So it is an integral part of the patient's management holistically. It's not a supportive measure. And liver disease, the European Association of Study of Liver. So it is international guideline all of you may refer to. So it also gives a separate guideline for the nutrition care of the patients. And also the ERAS guidelines for surgery, the medical officers who involved in surgery and the surgery wards may know that that is the well accepted guideline for the perioperative care of the patients. So in there also preoperative nutrition is an integral part. So likewise, these are only few examples. So nutrition management should be integrated into the overall patient care in the multidisciplinary team management. So it has to be emphasized and you have to understand that. Coming back for the patients once again, throughout the hospital stay of this patient, we gave personalized, tailor-made nutrition care. This I involved in management of this patient during my senior registrar period. So there were so many complications. Patients was on the deathbed so many times. And according to the patient's situation, we had to tailor make nutrition therapy. We had to go for parenteral nutrition, continuous feeding, and other supportive micronutrients. And when the patient came to the anabolic phase, the recovery phase, we had to go for high energy and protein provision. We used anabolic steroids and all the things we know under the world, we used on this patient in the correct time, in the correct way. So with the multidisciplinary team management, with the support of the other teams as well, patient recovered. And the second picture, after 2 weeks of the discharge, the patient became to this level who was about to die. So nutrition care can facilitate or the critical illness, the phase of critical illness and give a favorable outcome. So, ladies and gentlemen, my take-home message is nutrition care is not just a supportive measure anymore. It is an integral part of the patient management in the multidisciplinary team approach. After saying that, I will go for my main topic now. Right. Rethinking everyday food. This is actually very simple lecture. If you know these stuff, please tell me. I can skip the slides. Okay. This is actually not merely clinical nutrition. This is basically food science and basic sciences because a lot of people ask these questions, not only from us, but from you also. What type of the rice should I eat? Right? How should I use oil? Which oil is better? How many eggs should I eat per day? Those kind of questions are very common, not only from the nutrition people. In your day-to-day practice, patients ask in your private practice maybe. So you better have an evidence-based knowledge to explain the things because just rather than just telling the patients like parents, with the evidence, if you know these things, it is very solid knowledge. That's why I thought to discuss about these things today. So I will go with these three main foods. rice, oil, and eggs. Rice. This is the rice seed. Okay. So it has several parts. The outermost part is the hull, which is an inedible part, which is being removed during the processing. And then it is the next part is the rice bran. Right? අපි කියන්නේ කුරුට්ට කියලා. That is that rice bran. It contains a lot of nutrients, fiber-rich, vitamins, minerals, and antioxidants. So most of the B vitamins we need are contained in the bran, and also vitamin E. Then this rice germ also has some nutrients, phytochemicals, proteins, and vitamins. The rice kernel or the endosperm is the main part, which majority of the kernel is consist of carbohydrates, right? Having said that, I will go for the processing of rice or milling. During the processing, the first thing which is being done is dehulling. We remove the husk. Potta ivat. That is the main first step. Then it goes like paddy separator, destoner, and so and so. And at one point, the bran is being removed, right? And after that, after going on, when going on in the process, the germ also being removed. That part is actually the polishing or the milling. In the milling or polishing, we remove the bran and also the germ. So you can understand a lot of nutrients are removed during polishing, right? So various type of processing methods are used according to the industrial level and our normal අපේ ගමේ ගොඩේ තියෙන මෝලවල් වල වෙනස්, but at the industrial level they do most of the time they do polishing. So it is very important to understand this process. So if we stop at this point, like dehulling කරලා එතනින් නවත්තනවා නම්, so it contains bran and the germ in the rice seed. So that is very important. Okay. So there are some rice processing interventions to make the rice seed more nutriently stable and we can retain more nutrients. One is parboiling. We can, so that is parboiling. What we do in parboiling is the process of soaking, steaming, and drying paddy rice before removing the husk and bran. Right? I will come to that later in detail. The other processing methods are germination. Germination is that in the same way we can germinate the brown rice, right? So it also improves the nutrient value. And fortification. Fortification means we add micronutrients into the rice during processing. For example, salt iodization is a kind of fortification. Likewise, we can add iron or zinc or other minerals into rice because rice is widely used by the population. So through rice, by using a vehicle, so we can introduce micronutrients to people. That's the fortification. One example is golden rice, the biofortified with vitamin A. You may have heard. So those kind of processing methods can be used to improve the nutrient quality of the rice. So what is, I will be more elaborate on parboiling. During heating or steaming, the rice kernel get gelatinized, right? And it makes resistant starch, which is not readily digested and absorbed. That is the clinical application. I will come to that. And also, look at the third factor. During parboiling, some of the vitamins and minerals are absorbed into the endosperm, the rice kernel. So even after polishing, some of the micronutrients will be retained in the rising. So parboiling is very, very important in those aspects. So you can see this is RSC, the resistant starch. In these various types of rice, you can see in the parboiled rice, the resistant starch amount is comparatively high. And also, it directly affects the glycemic index. You can see, compared to the raw rice, the parboiled rice, the glycemic index is low. Right? Therefore, when you settle to the patients what type of rice you have to eat, you better tell that parboiled rice is better than raw rice because the glycemic index is low comparatively. So this is the comparison once again. So you can see this non-parboiled, unpolished rice, the glycemic index 50 to 65. And parboiled unpolished, 45 to 60. Parboiled polished, 50 to 65. Non-polished, non-parboiled polished rice. This is like our sudu kakulu, ratu kakulu kila dene. That type of rice, its glycemic index is very high, right? So that's why we have to advise to use parboiled rice. Okay. So that's the same thing I have elaborated here. Then අපේ තියෙනවා සුදු හාල් රතු හාල් කියලා. That is not about the brand. ඒක ඇවිල්ලා හාල්ලට කුරුට්ටි පාටේ තියෙන එක කියන්නේ. ඒකේ සංඝටක අනුව හැදිච්ච දෙයක්. right? එතකොට රතු හාල් කියලා කියන්නේ ඒකේ බ්‍රෑන්ඩ් එක තියනවා කියන එක නෙමෙයි. That thing we have to understand. සුදු හාල් වල වුණා අපි parboil කරලා dehydrate කරලා විතරක් නම් තියෙන්නේ. It contains brand. Okay, so that's the difference. If we go for milling and polishing, bran and germ is removed even in red rice or white rice. All right, I think it's clear. Okay. So what are the other factors that influence the glycemic index of rice? The amylose content. And amylose content in some of our traditional rice varieties like suwadal, pachaberumal, and kurulutuda, those kind of rice have a very high amylose content. Therefore, it is said that the glycemic index is low. The degree of milling and parboiling I said earlier, and cooking method. Overcooking increases GI, glycemic index. අපි බෙරිබත් නම් කන්න පුරුදු වෙලා ඉන්නේ, so it has very high glycemic index. Capable also, when you cook, it easily becomes overcooked. So its glycemic index is high. And cooking and reheating. This is a very important point. In cooking and reheating, increases resistant starch, lowering the glycemic index. You can even advise the patients on that. අපි උයලා තියලා ඉවර වෙලා ආපහු රත් කළ කරන සමහරලාට sometimes we microwave and eat. It is actually increase the resistant starch portion of the rice. Therefore, even you can advise the patients to do that. Right. Other thing is the rice variety, as I said earlier. Okay. I don't think this is very boring. I go for the oil. Right. Oil is also a very big topic in our society. Which oil to eat? Some people say that don't eat coconut oil and all. Don't use coconut. Go for olive oil type things. So what should we do? We have to understand the basics and the biochemistry of how the oil is made of to advise the patient. So this is the lipids. This is the categorization. The triglycerides are the main fat, the lipid component which is included in the fat we eat, triglycerides. So this is the molecular structure of the triglyceride. It contains the glycerol backbone and also 3 fatty acid chains. Right? Then the fatty acids are classified. One way is according to the nature of the hydrocarbon chain. I will come to that. And the chain length. According to the degree of saturation, we can classify the fatty acids. You can see in the topmost fatty acid chain, this part is the methyl or omega end, and this is the carboxyl end. So you can see there are no double bonds in between these carbon atoms. So this type of a fatty acid is called saturated fatty acid. Right? In second one, there's one double bond in the fatty acid chain. So they are called monounsaturated fatty acids or MOFA. In these two types, there are more than one double bonds in the fatty acid chains. They are called polyunsaturated fatty acids or PUFA. You may have heard those words. Right. What is the clinical application of these? The degree of saturation and clinical application. What is the connection between them? So the saturated fatty acids are mainly contained in animal fats, full fat dairy products, and tropical oils like coconut oil, palm oil. And it increases LDL levels. So there's enough evidence to say that saturated fatty acids increase LDL and increases atherosclerosis, cardiovascular disease risk. Monounsaturated or MOFA, it is contained in olive oil, canola oil, and nuts and seeds. It lowers LDL, so it is considered as a heart healthy fat. Polyunsaturated fatty acids, I will come to that in the next slide. So it has some separate unique things we have to understand. So current recommendation is to replace saturated fat intake with monounsaturated or polyunsaturated fats. That's the international recommendation. But not to cut fat totally from our diet or not to replace fat with carbs. We can't replace fat with carbs. That's what we usually do. We cut down fats but eat more rice or the carbs. That should not be the thing to do. So we have to replace the 30% of our energy requirement should be consisted of fats. So it should be either mono or polyunsaturated in the majority. That's the usual recommendation. Okay. Then the next categorization is the classification according to the chain length. So there are short chain fatty acids, carbon atoms 2 to 5. Then medium chain fatty acids, NCT C6 to C12. Long chain fatty acids C13 to C20. Very long chain fatty acids more than carbon 22. Right? So it's also very important when we come to the clinical management. The first factor you can see, short chain fatty acids are and medium chain fatty acids are directly absorbed into the portal circulation during the absorption from the small intestine. They are being directly absorbed to the portal circulation. But long chain fatty acids are not being directly absorbed to the portal circulation. They need micelle formation, they need pancreatic enzymes and bile salts. With the help of them, they are being absorbed into the lymphatics and make chylomicrons. Then they go in the circulation, and finally, after giving LDLs and all the other components, they come to the liver after a long time. But short chain and medium chain ones are directly go to the liver. So it's very, very important in managing some patients and some diseases. Right? So these are the therapeutic use of medium chain fatty acids. Actually, short chain ones are not available commercially in the industry, but MCT based, you may have heard. I may say the brand name for your knowledge, Peptamer, the peptide-based formula. Though they contain mainly medium chain fatty acids. So they are used in malabsorption syndromes, pancreatic insufficiency, cholestatic liver disease, short bowel syndrome, chylothorax. In those type of diseases, we preferably use MCT-based formula to improve the nutrition status of the patient. If we give long chain fatty acid, they cannot be either digested or absorbed because they don't have the particular bile salt are deficient or either pancreatic enzymes are deficient. So patient ultimately becomes malnourished. Another thing is these short chain fatty acids are produced in the colon by colonic bacteria by the fermentation of dietary fiber. So let's say there's a patient with short bowel syndrome, a considerable part of the intestine is lost but has colon. In that case, if we manage the patient nutritionally correctly, we can use this short-chain fatty acid, induce short-chain fatty acid formation in the colon and uh, get some energy from that. Actually, we can achieve like 500 to 1000 kcal per day from this fermentation of fiber. So it's very important, not for us, but for short bowel patients, it's really important. And the other thing is MCTs do not need carnitine transport system to enter into the cells. So they are used in like some genetic and metabolic disorders where carnitine deficiency in children mainly. In those patients also we use MCT based formula. Right. Apart from the degree of saturation and the chain length, there are two more additional facts about this fatty acids. One is the configuration, cis and trans fats, right? So in the topmost fatty acid chain, you can see in this the double bond, the two carbon atoms in double bond, the hydrogen atoms are in the same side of the chain, double bond. Right? So it is a little bit kinked. But here, the lower one, the hydrogen atoms are in the either side of the double bond. So it is straight. So upper one is the cis configuration, the lower one is the trans configuration. Right? And also, yes, there's another concept called essential fatty acids. In our body, in humans, we can't make double bonds after 9th carbon atom, right? There's a enzyme called desaturase, which is needed to make double bonds. In our body, in human body, we don't have desaturase enzymes to make double bonds after carbon 9. Therefore, this you can see that from omega M, this is the 9th carbon, and here also there's a double bond. So this double bond we can't form. Therefore, we essentially have to take these type of fatty acids from the food. If we don't take, we have some issues like essential fatty acid deficiency. Right? So omega-6 arachidonic acid, you may have heard linoleic acid, omega-6, and alpha-linoleic acid, LR, omega-3, which give rise to APA and DHA. These are essential fatty acids for humans. So we have to take them from food. Okay. Now what are the clinical applications? So regarding essential fatty acids, omega-6 mainly contained in vegetable oils like sunflower oil, safflower oil, corn oil, soybean oil. Omega-3 basically they contain in flaxseed. We don't use these type of seeds in our tradition, our culture, but these seeds are available in our markets. Mainly in supermarkets, we can purchase them. So it's you may, if affordable, can go for these seeds consumption because omega-3 is very important for our body. Flax seeds, chia seeds, walnuts, and oily fish. That is the main thing we can apply to our culture because we have a lot of fish now in our country. So what are the fish types we can use? Salmon, sardines, mackerel. අපේ රටේ තියෙන ඒවායින් බැලුවොත් සාලයෝ කුරුල්ලෝ ලින්නෝ බෝල්ලෝ කූරිමාළු වලින් and බලයෝ කෙලවල්ල ලොකු මාළු. Those types of fish are rich in omega-3. Right? And also there are commercially prepared fish oil preparations as well. So what are the importance of the omega-6? Actually, it's pro-inflammatory. You saw in the previous slide, it gives rise to arachidonic acid. So it in the pro-inflammatory and pro-thrombotic. And omega-3 is the one which is anti-inflammatory. Therefore, we have to maintain a ratio in the correct omega-6 to omega-3 in a correct ratio. If we take more of omega-6, it can induce a pro-inflammatory state in the body. So we don't have to calculate and take, but with omega-6, we have to take a sufficient amount of omega-3 as well to get the favorable the uses of these omega-3 and omega-6 fatty acids. So both omega-6 and omega-3 tend to lower plasma LDL, and omega-3 is special because it can lower plasma triglycerides as well. So we therapeutically also use in hypertriglyceridemia the omega-3 fatty acids, and in day-to-day life, in our diet, we can include omega-3 fatty acid containing food. At least the recommendation is you have to eat the fish I mentioned earlier at least 2 times per week. That is the usual recommendation. More is better. Right. This is about trans fat. I told about the configuration changes. So trans fat, this is the worst type of fat, and we really love to eat as well. Okay. So what are the food containing trans fat? This is a huge list. I mentioned everything, and there are many more, but most of them I have mentioned because we tend to eat these things very happily. Deep fried fast food, French fries, fried chicken. Usually in the weekend, like we feel to go to for outside food and eat this. Commercially baked food like cake, biscuits, muffin, pastries, donuts. Think about your children. What do they eat? Margarine packaged snacks like crackers, chips. Frozen food like frozen pizzas, ready-to-eat meals. There are plenty in the refrigerators in the supermarkets. Cream-filled products like cream biscuits, filled wafers, non-dairy creamers. They are there in the hotel rooms. And creamers. Instant food like instant noodles, like popular Maggi noodles and all, and soup powders, all contain trans fat. Right? Trans fat is actually mainly it is produced in industrial production because um, it is being produced in 2 ways. One is partial hydrogenation. That is, partial hydrogenation is it improves the stability and oxidative resistance and texture of the oil. Like margarine and shortening, so they are basically trans fat, partially hydrogenated vegetable oils. And also, trans fat can be formed by prolonged heating of oil and also repeated heating. If you reuse cooking oil, fry once and keep them and fry food again the same oil, that is reheating. From both those cooking methods, trans fat can be formed. So what's the impact on health? It increases LDL, lowers HDL, and increases TG. Promotes systemic inflammation, impairs endothelial function, increase insulin resistance, increase ACVD risk. Most importantly, there's no non-physiological benefits in human from this trans. So we deliberately eat what is useless but make disease in us. So think about this and think about your children as well. So I wanted to tell about shortening also. Shortening means a type of solid fat which used in food industry to make food flaky, crispy, and tender. So in the pastries you can remove the layers, flakes. So it contains shortening. It's mainly trans fat. Okay. So if you forget everything in my lecture, the other things, if you can remember this slide, it will be more than enough. Okay, right. Having said that, I will go for the hot topic, coconut oil, quickly. So you can see coconut oil in the top. it contains 92% of saturated fatty acids. So no doubt it increases LDL. Right? It contains mainly saturated. Look at olive oil. It contains mainly monounsaturated fatty acids. That's why we say it's heart healthy. So no doubt in it. So what we are going to do? Are we telling the patient not to eat coconut oil and buy olive oil? That's the problem. So there are some evidences. I'm not going to read everything at this point. We are all hungry. Anyway, this particular study says that this is actually, effect of coconut oil and cardiometabolic risk. It says that current evidence does not support promoting coconut oil as a heart-healthy cooking oil over unsaturated vegetable oil because its LDL cholesterol raising effect outweighs the increase in HDL cholesterol. I must say that coconut oil increases total cholesterol, increases LDL, however, it increases HDL as well, which is the good cholesterol. But the increment of LDL outweighs the increment of HDL. Therefore, they don't recommend coconut oil as a heart healthy oil. This is the well-known journal, Circulation, the journal, the official journal of American Heart Association. It has also said that best recommendation, consume coconut oil sparingly within a healthy dietary pattern. Right? Then there are some controversies as well. Some evidences are there. They say that the dietary recommendation to avoid consuming coconut oil due to its effect on lipid parameters are not justified. They say that in long term, the LDL change is variable by using of coconut oil. But HDL increment, you can see, I don't think you can see it. HDL increment is stable and stable throughout the research duration. And the decrease in triglyceride is very stable, but LDL variation changes with the time. Therefore, we can't say that coconut oil is not that bad. That's what this says. So, what are we going to do now? There are various things the research says. So, how do we advise the patients? What is the practical approach? The well-recognized international guidelines say that we have to use coconut oil sparingly, and from the biochemical aspect as well, the LDL, the saturated fats increase LDL. Therefore, we can say like we can't totally eliminate coconut oil from our food culture. We use them and they are particularly cheap comparatively. So we can't tell not to eat coconut oil or coconut. What we can say is use coconut oil and another polyunsaturated oil separately, alternatively. Right? One day if you use coconut oil, tomorrow you can use a sunflower oil or olive oil if it is affordable. Even change that. Other things are we can give some approximate targets for the patients. So these recommendations are being taken from our food-based dietary guidelines for Sri Lanka. I will show it later. So for 5 adults, for a family of 5 adults, one medium coconut is recommended for a day. That is one recommendation. වැඩිහිටියෝ 5 දෙනෙක් ඉන්න පවුලකට එක පොල් ගෙඩියක් use කරන්න පුළුවන් දවසට. And 1 tablespoon of oil per head. එක වැඩිහිටියෙකුට දවසටම තෙල් මේස හැම. So likewise, we can give measurable targets, right? And we can advise the patients to improve the food variety. Rather than eat the same thing every day, we can advise to add mono and polyunsaturated fatty acid containing food. One is available in our country is avocado. It mainly contains monounsaturated fatty acids. So we can easily tell the patients to use them. And also nuts and seeds. One of our studies done by our MRI nutrition team, the nuts and seeds consumption in our country is very, very low. Okay? But we have very cheap kind of nuts and seeds available. Peanuts maybe. And what about pumpkin seeds? very rich in omega-6 and also some omega-3 fatty acids. Do we eat or throw it away? Even we can give them for the children as well, pumpkin seeds. So likewise, we have to improve the variety and add some mono and polyunsaturated fatty acids containing food apart from coconut oil. Likewise, we have to advise the patient in a very careful and practical way, because we can't totally eliminate the coconut from our food culture. Right. The last topic is eggs. How many eggs we can eat per day? Any idea? How many eggs? Can we literally eat 5 eggs per day? 10? What do we tell for the patients? So just look at the egg yolk and egg white. Right? Egg yolk is which is the nutritionally very rich, and this is per 100 grams serve, raw weight. Calories are very high, 300s, compared to egg white, it's only 47 kcal. Protein, there are a very high amount of protein in egg yolk as well as egg white, 15 and 11 grams. I have to say that egg white is totally purely protein. Right? It doesn't contain any other fats. It's a purely protein containing egg white. But egg yolk, it has a total fat. For 100 grams serve, it has a total fat of 28 grams. Very high amount of fat. And saturated fat also 8.6 grams. Cholesterol 1050 milligrams. And other very important micronutrients as well. So what are we going to do now? These are some researchers, and this particular study has included about 1.7 million participants, right? And follow-up period is 32 years. So it's a huge study. And what they say is moderate egg consumption, that means up to 1 egg per day, can be included as part of healthy dietary pattern without increasing cardiovascular risk in general population. The overall dietary pattern is likely to have a greater impact on cardiovascular health than egg consumption alone. So the overall dietary pattern is which is most important, rather than questioning about the eggs, right? So 1 egg is totally okay for general population. So this is also says that this is also a huge study, and it says consumption of more than 1 egg per day was not associated with increased risk of cardiovascular outcomes. So this says that higher egg consumption was associated with the 11% lower risk of coronary artery disease. Look at the hazard ratio, 0.89, which is significant. And no significant association with stroke and other cardiovascular diseases. So shall we eat egg more then? Mind you that this study has been done in Caucasians, Western people. Right? So can we apply that same similarly to our people? Because we are genetically different. We are more prone to get metabolic diseases in lower BMIs. Our lean mass is low. In that case, can we apply this evidence as same for our population? And I found a study where South Asian population is also included. What does that say is moderate egg consumption up to 1 egg per day was not associated with increased cardiovascular risk in South Asian population. So there also it says 1 egg per day. Right. This is the recommendation in food-based dietary guidelines in Sri Lanka. A healthy adult can consume 1 egg daily. Age recommendation, if we don't like to adhere to our local recommendations, we can say American ones are better. So what does it say? Healthy adults up Up to 1 whole egg per day can be a part of the heart-healthy diet. Healthy old adults, up to 2 eggs per day. Focus on overall dietary pattern and limiting saturated fat rather than restricting eggs alone. And so, what we say for the patient. So, from all the evidences and all the recommendations in the guidelines, what we can say is 1 egg per day is safe for general population. And there are some instances, the special instances, where we have to give high protein diets. In that case, let's say there's a burn patient in ICU. Previously there was, we gave 8 eggs per day. So they are special situations. But we can't generalize those things and tell them other people that say to eat more and more eggs. There is some controversy in evidence, but it is safer to limit to 1 egg per day, generally, right? So that's the thing. For if we go for higher needs and higher amounts, it should be under supervision with specialized nutrition care. Right. Okay. This is the last slide. This is actually, have you seen this? Food-based dietary guidelines for Sri Lankans. This has been here in our country for a long time, but people don't know. This is in all 3 languages, Sinhala, Tamil, and English. Very simple explanations are there, very illustrative, so many pictures and all. It gives what are the serving sizes, what are the food groups, how much of those macronutrients we have to eat. Everything is there. But generally, if we want to advise the patients, you can refer to this without any problem. Everything is there. Fruits and vegetables, fiber, in pregnancy, how do we advise for children and everything, right? So you can Google it and download, and you can use it in your day-to-day practice as well. So this is the latest edition 2021 guideline. Okay, that's all for the day. And if you have questions, you can ask, or else we can wind up. Thank you.